Avuxeni, nami amukela eka rihanyo la Dr.Pru. Nongonoko lo mayelana nokubandzi lebyi lavaka na tsona. Kambe eka vanghana va hina va ta yi dyondzisa kusuka eka vana lavatsongo kuya eka vana lavakulu. Kanti futhi lolu hlelo luzonceda kulabo sebenza grade 11, grade 12 abafuna ukuqhubekisa izifundo zabo ukuthi babe odokotela, onesi nalokhu okunye. Namhlanje siqhubeka nodaba lwethu besiqale ngalo ebesikhuluma ngalo last week leli esithi usifo soshukela. Sizoqala ngazo izihambi zethu ukuthi ngobani kanti basuka kuphi. Uqale ngawe sisi la.
Sanibonani, gama lami ngokwanda, Mambo yi-dietitian.
Inkomo, vito ra mina ni Eric Chauke, ni tirha as a pharmacist and ni based Dutchman.
Kerebuha, nake nna mo go tsomole mabane, podiatrist wa rona ka maoto, ke sebetsa mo Gauteng.
Molweni Bukeri, gama lami Jimori Thabile Madoreni, the occupational therapist, and I'm also based in Johannesburg.
Dumelang, Lina la ka ke na Regina Mampane, I'm a physician endocrinologist ibereka Jombe.
Singasachithi isikhathi siqale ngaye uDokotela Regina. Dokotela Regina, siyazi ukuthi isifo soshukela sigcwele kakhulu la eSouth Africa kanti si-affecta abantu abaningi. Sifuna nje ukusithathe namhlanje ukusibekela ukuthi umuntu makasenyanga isifo soshukela ngabe nimtreata kanjani nenzani kubona.
Ngiyalebuka. Ge go na le bolwetse ba sukiri, go na le a medical treatment and go na le selo se re se bitsang a non-pharmacological treatment. Ge re bolela ka non-pharmacological, re advisa balwetse ba rena gore ba lebelele dilo tse e leng gobane ba di ja. So diet is very important ko bona. Re ba encourage gape le gore ba exercise at least 30 minutes 5 times a week. And then into important to make sure if banally other chronic conditions, high blood pressure, cholesterol, or to be well controlled, to be well managed. Kemuka only what is known as pharmacological management. So pharmacological management will depend on type 1 diabetes, type 2 diabetes, or what is known as gestational diabetes. But we have type 1 diabetes because bona have pancreas produce insulin at all. Treatment ya bona ki insulin. So bona if basa humane insulin, ba kona go wala ba what is known as DKA. So ba aba kono gore ba phile without insulin. Ke mga batho ba ba type 2 diabetes bona because of their insulin resistant. So pancreas is going to produce insulin, but insulin is not for the entire bereka. Ba management wa bona ke gore re ba fa something e ba e bitang gore ke insulin sensitizer. Take drug and insulin sensitizer pilisi tse leng gore ba di bitsa gore ke metformin. So bona ba kana ba start go metformin ge le go ba controlla dilo tse dintsi. Ba kona gore ba be on just metformin. If ba le gore ba controlled on metformin, re kona go add another tablet e leng gore e produce pancreas go produce insulin, yona known as diclofenac. So those patients ba kona gore re-add to their metformin to eba e bitsang gore ke diclofenac. Ke ba gona le another group ya medication known as GLP-1 and analogs, and then another group as well known as DPP-4 inhibitors, another group A the glucose 4 transporter 2 inhibitors.
I think Mr. Eric here na tla tseya pila gore di bereka jwang di etsa. Dr. Regina, re ya go tseba gore COVID ra bona batho go na le COVID bona ba no ke bolwetse ba swekere nka re di tsamaya ke mate ke leme le parking le saliva. So regarding ka COVID le bolwetse ba swekere.
Oh, unfortunately, bolwetse ba swekere bo produce batho ba bantsi to the infections. So if you're poorly controlled, but humana no gore batho ba bantsi ba ile gore ba na le bolwetse ba swekere ba outcome ya bona from COVID mainly poor, mainly because never see controlled, especially but about HbA1c, then already more than 11. Never because of that, it's riskier for they are immunosuppressed from the diabetes. So the outcome is really poor from COVID.
Dr. Jai. Mr. Eric, as you said, you are a pharmacist. Key pharmacist. Libereka Joan can put us pharmacist.
Okay. A pharmacist is a healthcare worker or a healthcare professional. Mainly the focus here training is into the main disease states that are happening on a human being, but the basis of training you participate. So the main part ya pharmacist ikutiba kwenda miri, and then ukutiba kwenda miri le ufanele ukutiba kuyitira njani miri wamuntu, ufanele ukutiba kuyienda njani yona, meaning kuyaka production and make those tablets that the doctor ablabled. Training yakona yi take 4 years of full-time training at university, and then after so now we enter internship, and internship yakona may enter hospital or may enter even in a manufacturing setup, and then we enter na community service internship after that na community service. So in short, that's what a pharmacist has to go through. Ufika stage as a pharmacist, which means so it has to take 6 years by the time we as a pharmacist in the community. Material kuna different fields that the pharmacist one of them the manufacturing industry, now enter PDC and produce and then the next level in hospital pharmacy. So the pharmacist can be government hospital or private hospitals. Then another sector which we refer as retail pharmacy or community pharmacy. The pharmacists within the communities. Some of them operate in shopping centers or right within residential areas, and then the last one into academy, but train more new pharmacists.
Dr. Jana Obuletika type 1 for insulin, of which he injection. Governor of the says over American Joan injection in. Haizena omile. Kanti di fapana biang hapeli injection is like type 2 the injections there insulin there hospital la hemutu anali sugiri enchi azena hospital la drip. Di fapana biang injection is.
Okay, yeah. So insulin as ishtiba who the main hormone you who controller sugar mirin is that insulin. So type 1 diabetes meaning producing enough insulin to move sugar from engatini to the cells around in your body. So for Banvala so that's where insulin. So in other words, you are boosting the immune the insulin levels in wa patient jaleyo. Once over injected that insulin, you to move the glucose you are angatin into the cells so that a lower level or like a level that is expected for a body to function with. So those I would say those are the main ones that let's develop the receiver in on patients.
Dr. Pru, let's have a go. Please, metformin, especially metformin. Can't buy a rat that didn't have metformin. Who can cause it over? Even a drug metformin.
Okay, so metformin ya imapilisi lawa yatirhiswaka depending ka level ya vuvabyi. So kuna like I said, the way yi dosiwaka hi kona kuna vanhu lava va a low dose but va yi tirhisa like 3 times a day so that va kota ku maintain a good level ya yona engatini, kasi kuna nkarhi la dose ya kona yi va yi much higher, and then munhu a kota ku yi tirhisa kambirhi a sikwini instead of 3 times a day, and then in some instances kuna leti nga slow release metformin tablets. So yona, as it does sensitize the uptake of glucose from the system. So improve the ability to measure glucose from lying alabic gona into the cells, and then you na delay absorption ya chukele from like lokuse unjeswa kudya kuna chukele acquiring that absorption yumelela amarumzini, which is the intestine, kuyiva yiri delayed. So in other ways not too much absorption of the sugar into the blood circulation. So those are the main ways that and then also the actual you prevent an shipping from produce sugar into the system. So most of the time there are different ways where your liver produces glucose or sugar in your blood system. So with metformin, you block that process. Block that process, you also sensitize your system to be more responsive to insulin, and then on the other hand, you delay absorption. So you in different ways, and that's how patients benefit. And it's one of the old medication. It's still very useful.
With me, but believe metformin mauto a thoma a methalile dirisemo or metformin nkare ke tlo ba di renal failure ka speed o ka renga metformin ko bathong ka tjena.
Metformin, the excretion you find by which is the kidneys. So obviously, because the excretion is through the kidneys, the likelihood is that without going to the fingers into metformin, you damage the kidneys. But normally, the test the creatinine level in a patient, which determines how the level of excretion or the functioning of the kidneys. And obviously, the patient any issues with the kidney functions, but treatment monitor. For Munoi already a compromised kidney function, but that are going to test that more often, times 2 to 4 times a year. Because normal na kidney issues still by monitor to make sure expose more other additional problems or health conditions.
Is there a mechanism where metformin the weight loss? Because the patient, weight.
Well, in that case, I think that's obviously the belief is one but I think it might be driven by the fact it interferes with the glucose usage. So when our problem you digest glucose well yourself, and then you go in and interfere again with your glucose management. The likelihood, as we know, chukele logorilla absorbwanga amirini. I mean, logorilla in abundance that and move over into your cells, it gets stored as energy, and whatever is stored as energy, it ends up becoming the weight gain that we see. So, the likelihood is that one connect those kind of mechanisms with local. Even if I start interfering with that part, it means I won't have more of the sugar that is piling up as energy that is not used. But I should honestly, most of the medical personnel should encourage that because it can be very harmful. There is a risk also if your glucose control and then you start interfering with that, drop sugar to levels that you think are more harmful for your body.
Sekukhona le treatment entsha dokotela lakhuluma ngayo lana ungabe usithatheke yona ukuthi isebenza kanjani ngoba nokuva ukuthi ngathi yona i-right uma renal failure iya protect ukuthi ungafiki ku renal failure iya protect ukuthi ungabi nabo cardiac failure isebenza kanjani le treatment entsha yoshukela.
Okay, so I hope the sodium, the SGLT2, the sodium glucose co-transporter inhibitors. So those ones, the relevant is that they actually increase more the excretion from your system into the urine, because obviously this was from the kidneys. So that way it ends up assisting more in terms of regulating your retained sugar in your system, and and it has been claimed for chronic kidney diseases it is more helpful in protecting the patient.
Wow. Mr. Ndlovu, njengomuntu ophile nesifo soshukela esikhathi eside, ingabe wena iyiphi i-treatment oyithathayo kumanje?
Khona manje ngithatha i-lentus. Umjovo.
Okay. Mara uke wayithatha maybe ku-metformin
Yes, ngiqale angithi metformin ne-glucofage into eyi-one.
Yes.
Sekuya nekhampani eyiprodusayo.
Yeah.
So ngiqale ngayo i-glucofage and then ne-dimacron.
Okay.
Zizama
Yini dimacron lapho Dr. Eric? Awuchazele yini dimacron?
Well, it's an oral antidiabetic. In terms of the control of the sugar in your system, and also encouraging the insulin sensitivity.
So every time when you take metformin, you have to take it with another drug.
Yeah, usually we combine because of the material we are different. So on one side you are stimulating the insulin responsiveness, which you also do get, by the way, metformin with sensitizing your body to respond to the insulin that, the minimum that you've got in your system.
Okay, that's clear. Then
and then asuka lapho default attribute as sunseeds.
Oh.
Then nazima sunseeds bamfaka ku-injection. Ngayithatha le-injection ngaqhubeka no-default yana-sunseeds. Bafaka enye injection engabona ukuthi manje sengizobulawa imjovo. Ngaqala
ucomply.
Mara kwamanje ngithatha 2 imijovo. The short stay, and then the short active, the long active. Lentus is a long active, and then Ungibaleka.
Neborapid.
Wow.
Neborapid now ile uyithatha nawuqeda ukudla or ukudla. Ukuthi lo kudla kungenzi next life.
Babendlovu mani uyayazi lento mani uyazi ukudlula kudokotela ungazoba i-ambassador yesifo soshukela kumuntu Mr. Eric nawe uyayibeka abo-short acting long acting kwenzakalani manje ngale mjovo yabo long acting nabo-short acting?
Yeah, going like the long acting, at least it's something it's got to do with the half-life. So the half-life here, that kind of product, you buy really much longer, you got a controller for Garolea. And, you know, when Munangale Kujeni, Swakuja, Garaleo, Ukumaku, your sugar level, you buy maintained to a certain, you know, required level for a diabetic. Because the short acting as the done of Abula normally you get your postprandial where your sugar sort of like picks up after and that's where the product those short acting, but they are rapid in terms of their action. That's the actor a bit slower but more steady for a longer period. That way we got to maintain the sugar control yamubantu.
Namhlanje sichazelekile ngemijovo ne-treatment yoshukela. Kanti ngaphambi kokuba siye kulaba abanye, Mr. Eric, ngifuna ukubukisisa la. Uma ngabe umuntu ethatha le mijovo or amaphilisi oshukela, elinye neliphilisi siyazi ukuthi line side effects. Ngisho ipanado ungayithatha kuba khona ama-side effects. Njengabanje ngoba bakhala ngomjovo immunization le-COVID ukuthi kunama-side effects. Yonke into esithatha ngisho le-brufen ine-side effects. Yimali ama-side effects wale treatment yeshukela kanti especially lawo ayi-life threatening?
Okay, I think earlier on, Dr. who had up conditions like acidosis. Yes. So kuna mabilis one ya trigger such effects, and which can be quite harmful to the body, and also can be lethal. I mean, they can be deadly if they are not managed well. Like you're now with the lactic acidosis because of that rise in the lactic acid or the acid in the system or the serum, and then, but in addition to that, respiratory distress that can be seen, and then the other effects which may not necessarily be that deadly like your gastrointestinal one. Kasi kuna mkarimwan la muna abago into some of the medication they think abisaga into a hypoglycemic level, so ila say together abago really drop then which is not needed and it needs to be managed properly. Kuna I think like when you get keto, I think it's what ketoacidosis. Also, some of these sodium glucose transporter products can, lead to some of those kind of conditions which, needs to be managed carefully. But one of the bigger ones, I think, the acidosis usually, in most cases, if it's not properly managed, it can be, it can lead to fatal outcomes.
Mr. Eric, ngike ngaphikaya uzuvele kabanzi nge-treatment yokulapha isifo soshukela. Sesingena lapho ke okubaluleke khona manje la einyaweni. Mr. Ndlovu uke washo ukuthi uke waba nesilonda. Maybe before kuba nesilonda bekwenzakala nje la einyaweni zakho, yini mhlawumbe into okuvama ukuyiva la einyaweni zakho?
Hayi bekulunga kodwa ngithola ukuthi kukhuluma kamnandi nje. Yeah, now kuyaluma lenyawo kodwa nawo lokho libamba ulithi hayi kumnandi kanti nawo lokho kwenza kanje uyazivula
Awu.
Then nasesivulekile siyaqala manje sichitha ama-fruits sicala ukuba painful and manje nokunyathela sekubanzima ukunyathela nje kubanzima.
Mr. Efi, wena podiatrist.
Yes.
Ngikopela ukuthi le batho highway. Ke ni podiatrist itse ha sebaka se kana kana ngoba podiatrist kanti le bereka ka eng lena?
Ke a leboga doc. So podiatrist ke ngaka ya medical professional o sebetsang ka maoto dipenkele mangwele le letsheko sometimes ba ipana go sebetsa ka maoto fela but then o tsamaya ka teng for example ke tsa letsheka la go le botlhoko ba mangwele so sebetsa ka maoto jaaka papana go go nana le dintho go maotong dintho maoto a chisang a batang a bokgang ba bang ba ngale maoto fela basics le go ga maoto go fufulela ga maoto then gape go na le rona ba ba sebetsa ka di athletes go na batho ba matha rugby players soccer players and then le ba na ba sebetsa ka bana ba sa le banyana like go ba le go tla futhi ya tsolo ngwana tla bile assesswe ke podiatrist and favorite orthopedic wa mo tse thusi sa duminyana and then podiatrist mo Africa ka ofela is study ko UJ fela. So some of the subjects into West Medical School like pathology, but the main University of Johannesburg, Africa, in 4 years, and then in work-based training. So from second year, already patient to clinic, Jovet Jen, Tapu Memorial Hospital, Bara, Helen Joseph, and some of the local clinics. The students from second year were already patient until 4th year. Then from there, I registered a professional counsel or practice separate.
Okay. So, in that intro, since I'm going to Mauda High, since I'm going to Abonsa Lena is podiatrist. King in it, Mutana will be Basuke, or Tanzania Bonemi, Tanzania Bone, Henry Luana, or Kinano Lawyer Fella, podiatrist, just for mode, or especially by Basuke. Utsonza ke mo lenaneng e setse ba bona iso ka bane
ko doctor hello go sebetsa sentle because remember to get a teamwork.
Yes.
So that they have to diagnose you ke doctor high doctor tsentsa mlela go to get perfect amount wa ha on the day at diagnosis tsentsa ba lepela go la optometrist podiatrist dietitian so ganzi the patient that are going to have a really na bo mo tsukela that have physical diagnosis ba so doctor o focus the mo so some of those conversations are every day and then so mo tsukela from the get go ga physical diagnosis ka tshwanetse tsa bona podiatrist then podiatrist tsa go for education go papa ka ba tsile if na go podiatrist go ba aska mo education ka ba it was before our problem isn't after our problem go la abula le go aska because I remember le tsukela affect ma so effectively matlo o khata lenala o ka nne months o botswa ntho e so ke educational response ba ithola from diagnosis and then ge a fetsa go ithola ga tla go bona from there if asthma complication what is a year it's good enough for every year I check you I feel education for example motho le tsukela go chase ha go ba ha tla le bona le tla ha go itina na ba tla rata go itsa ntho jwa ha tla le tsa ma barefoot to so bane go bane motho a tsukile a gele ba go bile ka pele ba tsona le neuropathy le gore ga o receive so ha tsa ba ka maoto a ka tlhalwa ke something a suppressive a se bone le mali a gele matlo ga go le a nna le selo tla se la go le mo hang if motho mo go ntlo mo a bona wa etsa le so la ka tsene diabetes to inspect mouth every day ga fetso tla so since that's what I know when I diagnosed ki doctor ki nurse or ki mom part of the treatment plan in the education go so to bona ka mo and before we get another thing is most of the diabetes study actually when diagnosed by identify the podiatrist so moto jaga doctor ki go go it's a silent killer so moto na le tswiki ra ha diagnosed mal mo ta pa cheese or abata or the atlaba doctor na go tlaba abata because of the podiatrist mo sa feel yo ga ba itlela e be ketsa ding e be mo ga nne this could be diabetes then to bona ka mo sa those questions are what can come out so mo to kwetsa ga la mo bile and then go mo fela go doctor ba mo diagnose and then between another doctor that's when you build the team of like one of the dietitian or optometrist And that's how ideally part of the to say
Dingaka go high, dingaka go dipetlele, dingaka go ditleliniking. A re ithuteng go refera balwetse ba rena go di-podiatrist. Today ke ithutile tse ngata ka podiatrist e ne ke sa tsebe ka yona gore e important ka eng mo maotong. Ke utlwa a bolela ka gore go na le peripheral neuropathy ya gore batho a ba sa utlwa maoto a bona, and nna ntho eo ne ke itse gore e ke di-occupational therapist. Also, o ka re botsa gore ke eng occupational therapist kante gape le bereka jwang, especially mo motho wa diabetes. O ka reng ko rena dingaka gore tshwanetse re ba refere go lena neng?
Occupational therapist is a health professional responsible to assess and then treat and manage any occupational dysfunctions as well as any physical conditions or mental or psychosocial conditions. So which means that a lot of times, though, abantu they actually present occupational dysfunctions more than the conditions themselves because they don't have a clinical inclination. So I was driving and then I started feeling a discomfort, or I started going to the bathroom frequently, or I started getting disoriented, or and so on and so forth. So those are occupational dysfunctions. So in understanding that, unless we are fully occupational, then we are not healthy, because someone is not going to say, I think I'm diabetic. They'll say, suddenly, I is scoring and cause magama. So those are the occupational areas that I am referring to. And then on the issue of diabetes, most commonly, all the khabadins, which means about they would want to refer to occupational therapy and physio right at the tail end when patients have sustained what you call secondary complications of diabetes. So when there's already an amputation, when there's already a visual impairment, either mild or progress in terms of a patient sustaining secondary complications. And specifically with diabetes, to say that all of these things. The moment a patient is diagnosed with diagnosis with diabetes, there's a change in their routine, there's a change in their occupational profile, and the patient must take an active responsibility in terms of managing the condition. So in progression in diagnosis, diabetes depends entirely on what you call an active role by the patient. There's a term in occupational therapy, we call it DSM, which is diabetes self-management. So unless that person monitors their glucose level, unless they take their insulin, unless they're compliant to their diet, unless they monitor their glucose on a daily basis, they're not going to be able to manage the condition. So when occupational therapist comes in then, is on the motivating aspect, to say that because patients do become despondent, we were relapsed several times. There's a term in our books that we call diabetes overwhelm. Is a distress. So there is someone who's going to say, let me look at your occupational profile. Let us see within your daily activities how then we factor in this new you who must keep you alive. Does it make sense? So you look at the activity profile and say, you can also be active whilst you be drug, so that there is that weight loss that has been prescribed by a dietitian. So and also the issue of the psychosocial component of being diagnosed with a chronic medical condition. Right? So we then come in, so issues like group treatment, where then we expose you to a greater team who has been in this journey, and the fact that there's what you call altruism. So if Unayolendo and universality, I have been diagnosed with diabetes, I've had ABCD, and this is where I am now. So an occupational therapist is then going to facilitate those group therapies, because the psychosocial component is actually always left behind. No one wants to find out how are you interpreting this chronic diagnosis that you've just been given, but want people to comply, and we don't understand what are the psychosocial aspects that make people not to be compliant into their own medication. So as soon as you get this diabetes, you say, what now? what do I do with my daily activities? And it's quite interesting to say that within the South African model, only less than 2% of diabetes referrals are taken to occupational therapists at this stage. So the greatest number of referrals would then come in when there is legal that you can do in terms of stagnating the condition, but now we're already compensating for permanently lost functions.
Wayibeka uLithabile i-occupational yacaca. Ngiyathemba ukuthi nathi sibodokotela siyafunda namhlanje ukuthi kungani kufanele sithumele ama-patient kuma-podiatrist, kungani sifanele siwathumele kubo occupational therapist kusese-early kungakabi nama-complication. Babendlovu, uthishere une-renal failure ufanele uhambe kuma-dialysis. Kuyi-affecta kanjani umsebenzi wakho yonke lento?
Hey, iyayi-affecta impela. Ngoba kwesinye isikhathi akufani uvuka ukhathele, umzimba lo ukhathele, akuvuki ukuthi usukume ume. Yebo. Manje iyayi-affecta impela.
Umsebenzini usaya kwenzakalani manje?
Hayi, umsebenzini ngigcine 2019.
Bese kuyisikhathi sakho sokuma noma bekulokhu?
Ngoba isikhathi sami sokuma kulo nyaka kodwa ngime 2019.
Lithabile, sinceda kanjani ukuthi umuntu aqhubeke manje azawufika kubo 65 ayekele emsebenzini because sokuyi-pension angayekeliswa ukugula sibanceda kanjani?
Enkosi sisi, ugqirha bekhe wathetha apha uthe eSouth Africa we have about 2 million people who are known, who are diagnosed with diabetes. So if we can take those people out of employment, when we have a crisis of unemployment, we're just exacerbating ingxaki esihleli. So there needs to be people who are going to intervene to keep people as employed and as functional as they can, or for the longest time, because they are able to then use the livelihood, the income emakhaya. Now, when we come in then as an occupational therapist is that there is no one size fits all in terms of functional recovery. So what is important that we do is to conduct what you call a functional capacity evaluation. So you cannot say, wonke umuntu one diabetes, this is for how long they'll be able to work, or these are the challenges. Any person has got their own story, and the functional ability is determined not more than by the clinical condition itself, by the other issues, psychosocial issues, how much is the motivation in Kaya, who and all of these other issues. So you can therefore say that diabetic, this is how you then go to structure their work. And individualized functional capacity evaluation becomes critical. And also activity demands of a teacher is going to be different than that of a doctor, and then that of a driver, and then that of a policeman. So you must then understand, what could be reasons for occupational dysfunctions in diabetes, right? So there is conditions like neuropathies, which have been explained in detail by our colleagues previously, and then there's issues of issues of fatigue. So an occupational therapist is going to determine the physical demands, the cognitive demands, are you in a mental state, and then the social demands, because people have got their own stereotypes and perceptions around certain conditions, including diabetes. Do you understand? So the moment you sit about they will come with all of their theories and everything else. So you then need to empower a person to say, so not just the physical issues, to say, if you're working for 10 hours, you can do this job in an alternative manner and and almost alter it. We then need to look at the psychosocial components of that job. How do you empower a person to be able to respond to all the perceptions around diabetes? If someone suddenly opens an article about people dying of diabetes, and I'm seated here and I'm diagnosed, how do I receive that information? So us preparing people or assisting people to remain employed is not only limited to the cognitive or to the physical aspects of the condition, but the psychosocial and the social components of a condition. So a functional capacity evaluation for each person becomes critical, because there is a different approach in dealing with our patients.
E-diabetes akusiyo ekukhipha emsebenzini ngeke
Okay.
Inayodwa ngeyo ngingaqaluza 96 kodwa icala kumhlupha 2019 ngoba sekuvuleleke lamanye amabanga
Secondary issues.
yabona sekune high blood sekune renal failure and lezo ke manje nohulumeni akasavumi ukuthi uyosebenza una utreat ama chronic ifo ilokho umhlanje
Hey,
not diabetes
i-diabetes
uyaqhubeka nokusebenza
uphile normal.
Yes.
Ngiyathemba niyavakala lidlapha emakhaya. Kanti-ke Rithabile ngifuna sicacise la. Umuntu besisebenzela ekwazi ukubona lapha nalaphayana, akwazi ukwenza 1 2 3 kunganama-pain and needles enyaweni. Lokho especially ukuthi uthola ukuthi akasaboni kahle, so nabo retinopathy, so ne-dialysis njengobabe, wonke lama complication unawo. Nimnceda njani futhi as occupational ukuthi abe independent?
Okay. Again, it's very important that we understand the visual impairment you teach about. To what extent is it? Because sometimes we don't want to compensate for the function that is not lost. So there is a room for you to then refer back to an optometrist or an ophthalmologist. But once you get a diagnosis or a prognosis that says that we've almost reached a level where there could be an improvement, then you start with a compensatory technique. Now again, you need to analyze because sometimes if we're speaking about visual impairments, certain jobs have got different visual acuity demands, right? So for instance, me as a plumber or me as someone who's a seamstress, my visual acuity demands are different than me being an administrator. Does it make sense? So there needs to be more focused in what I'm doing in terms of my eye issues and so on and so forth. So you need then to understand in yoga if there's a visual impairment, what are the visual acuity demands for this particular job? And therefore the treatment then, or the compensatory treatment is going to sometimes be based specifically on those demands of a job. And sometimes our affected engagement. Sometimes even though you find that then the left eye will be more affected and then any measure will then join in. So it's very important to save the non-affected eye.
Yeah.
So our compensating for both, hence that assessments then become critical. So you don't expose them into an activity wherein if you need it's going to then start having issues. Does it make sense? So it's very difficult to respond to a question because your question would require an individualized assessment to say when's are done and what is the extent of your pathology or your impairment. Same applies to neuropathies. If there's a nerve impairment, which is what you call, I think one of the doctors explained this as a microvascular issue. A nerve, you can have a diminished sensation. You can have a total loss of sensation. So because of that, in other issues, you are retraining the impulses as an occupational therapist because there is just a damage, but there is no complete lesion. But for others, you find that the hypersensitivity or the irritation which is found in neuropathies or in the olden days when we could not manage HIV as complications of certain antiretrovirals who get you neuropathies. That's just a hypersensitivity of a nerve, and your approach into treating that is different from someone who has had a total lesion, wherein they are unable then to have any sensation. And an issue where there is a complete lesion in that nerve, the issue now, which is a direct focus for us, is the issue of safety. Because the nerves are the ones that protect us, right? In fact, that pain sensation or whatever sensation that you receive is the one that tells you there's something wrong within your body. So issues of pressure sores and all of these other things because of bony prominences, I must actually change my position. So the education that says use your eyes, but in areas where it's in the where your eyes can then compensate, there's other techniques that you use. So the issue of assessment becomes critical because in some instances, we don't want to compensate for a function that is not lost. If there's just an impairment in the nerve, we'd want to retreat and redirect the impulses. But where there's a complete neurological damage and there's loss of sensation, then that's when now the compensatory techniques comes in to say that instead of doing A, do B. So you're no longer now retraining your impulses to reinterpret the altered nervous systems.
Tata since mo ore maoto na tsulesiso lena as podiatrist diwana nyaka treatment ya nena ya no or ida ka maoto.
So treatment ya maoto fa tsulesiso patient are referred or isolated. First is when the bone of the cases of the job, but remember when neuropathic ulcers maybe patient have feeling then a diabetic ulcer where the sugar was high, patient may develop a blister, especially in the big toe. And so you have to identify, sometimes it can be a vascular. So because neuropathic ulcers, then vascular ulcers where there's the artery block. So first thing to identify why did you develop? Perfect develop this tweaking relevant at the site of the wound. So for example, I have Papa So if you it means for Papa kidney teacher. So the type of shoes that Papa had roll because they don't need a cushion. So is the wound infected? The wound infected. Sometimes we talk about IV antibiotics so once you control that, the most important other thing that we mentioned why it developed was the sugar high. Because remember nerves, and I cannot diminish vitamin B12, which is very important. So the referring doctor, or if some referral doctor to address it, then we can not only the hard skin around it, the bride, take it with the bride around it, because no help no fall if it's clean like the infection, then right rise. Then patient normally it's a very expensive thing, that's why the patient didn't need it. Because patient will often say initially they are half-meters, so that is weekend after every 5 days. And then once you can develop a wound diabetes, chances of recurrence they high. So chances of it will develop a high. Yes, so that's why now after you if Papa that's in the wrong, we can make insoles, the cushioning. So that at least, because I know all of us as we age, we depend around the food affair. So we make sure now to get it out ways, we make sure we protect the food. If no problem, 5 hours a teacher. I already had leather or I don't know, maybe we need to get only diabetic shoes, only take it, we can make cushioning, float in there, we can have pressure. So that's how you do it. But now from there, the patient then already over high risk because chances of recurrence is high. And I remember the other reason why I want to treat this wounds is issue amputation.
Yes.
So that wound can get infected or septicemia. So the earlier the better. And about someone who has a problem of the heart develop a wound. Now we know that I will let them or told that what's happening or everything to them. But I'm not going to shape there. We are going to be. We are going to understand? And then Batabo when I join first holiday. And sometimes the other thing is and the other stigma. What develop these wounds, they smell young. They affect the relationships about in other families to in a different because a high young because some has so all of the psychological aspect of it. So most of the patients that it actually if you're diabetic or working a small thing. Rather we are clinic or go to how rather is nothing than for Emma, especially when that sometimes even though we want to prevent amputation, sometimes amputation is the best solution. Because if one side big toe to protect the second toe there and protect the chance so sometimes you know here there's nothing, there's wet gun green is finished white. And then happy to that you always work with vascular surgeons so that they need to check what is there. Because otherwise, hope treatment, develop prognosis, can this heal? I always tell my patient this can take 9 months. So from the get-go, you know this is going to be a long time. In that 9 months, what are we going to do? What's our first plan? If we're infection, we're going to say infection, and we're going to deal with pain. Because some of them actually have a sick wound, they actually pain in the wound. So there are those things, and then we treat it. And then I always tell the patient, always want to care about. I want a doctor into some patient that to care. If patient that to care, I choose. Because you can come, I can give you the most expensive dressing material. You are setting me back. So when it comes to managing these things that you can get teamwork, and I tell my patients you are a doctor too. Because I give you when we can sit there like the doctor, I'm not medication 2 days before I go consult. And then another time check this patient is fine, why make this a fool? So that thing about the patient is about that's what people are doing. We health professionals, more how dependent we are dependent on each other. Understand? And then another thing that they want to is wounds. The patient there, the trial, honey, people try homemade things. But what about somebody that's saying time is massive. You need the sooner the corona, the better for you. So the wound is and then another issue because my ones are well in neuropathy where you don't feel anything. So even if your shoes are tight, because most people make a mistake in the morning, but you should actually buy your shoes in the afternoon. That's why most people would have a mental child, at least be tight. So like actually this is not exercise. So all I need to kill. Just like some greatly too tight. Some the matter some cons or how that friction from the attack to develop a wound. So that's the other main thing is to Yankee. But I would make Baba Osha and all of those things. But you buy a shoe you don't do that the first time. So as a diabetic, those are the things that you should avoid. So what are the neuropathy? How does it go for and then global problem
ezempilo zwamutakalo iletha isifundo esikhulu ebenami bengasazi ukuthenga isicathulo umntambama kubaluleke and shopping sithande kuseni mose so namhlanje sifundile kakhulu akezingena ubabendlovu bewasho wathi ukudla kufanele adle nabaningi nodokotela nje bashilo last week ukuthi kufanele udle kahle exercise sisinokwane ngiyaphila njani sisi njenge-dietitian ngicela uchazela abantu ukuthi mina as dietitian nama-nutritionist ngihluka kanjani?
Okay, ngiyabonga Dr.Pru. Dietitians nama-nutritionists, umehluko, the biggest thing is ukuthi dietitians work more in a clinical setting, so that's in hospitals, doing therapeutic nutrition, so dealing with complicated nutrition-related conditions. Nutritionists, on the other hand, would work in the community, so at population community level, where most of the time they are educating or advocating for nutrition-related concepts, depending on the community, what are the needs of the community at the time. So that's really what a nutritionist is. But I have to say, Uti, a nutritionist cannot be a dietitian unless they study, of course, right? Study dietetics. Okay. But a dietitian, automatically, by being a dietitian, you also qualify as being a nutritionist. So by this I mean, Uti, as a dietitian, I can work in a hospital setting, but also if I want to work in a community population level, that's also possible because I have Leo accreditation. You find with some dietitians RD, some RDN, meaning the exact same thing, but you are a dietitian and a nutritionist. But a nutritionist will always just be a nutritionist. There's also other courses that you do online, or about courses in nutrition, nutrition coach, or all of those things. Yeah, but those are not nutritionists really. There's like, there's like a new law which you can't really use words like that. So yeah.
Okay. Njengoba usucacisile ukuthi ngisebenza kanjani ngihluka kanjani kwa-nutrition. Umuntu onesifo seshukela njengoba Ukuphi ukudla kufanele akudle? Iyiphi breakfast afanele ayidle?
Okay. It would need a consultation. It's an individualized thing, right? So sibuka wena as a patient, what's it? Okay, diabetes of course is your concern, but what's your religion? What are traditions as a kaya? What you celebrate? What is activity yako? Like occupation wise, what's your activity level and all of those things. So we look at those things and then we draft a plan for you. So it's now it's a consultation and go on. But essentially in a nutshell, it's always a balanced diet, whether it's like breakfast, lunch, supper, or snacks in between. It always needs to be balanced. When it's balanced, I'm talking about a diet that consists of food groups, starch, there must be veg, there must be fruits, there must be proteins, there must also be the good types of fats. So to answer your question, for a balanced a breakfast for someone who is diabetic, definitely needs to incorporate all of those things. So it could be you are having a sandwich for breakfast, maybe, or even if it's lunch. Always make sure for the starch sample needs to be whole grain or whole wheat, brown starch basically, right? Because you need that, it helps in regulating your sugar levels nicely. So it would be a nice bread, make sure that you have a veggie, and then you can have a fruit and maybe put in an egg into your sandwich or any other protein, like inyama, or put in fish or any beans or things like that. But essentially, you definitely need to consult with the dietitian, not just because your friend now you're diabetic and then for breakfast, because it's going to be a problem. And also another thing is portion sizes. Just because your friend only breakfast and with a quick bowl doesn't mean you should do the same thing, because you are different and dietitians are going to be different.
Okay. Usabamba la kuma-fruits. Ngicela sisingene kuma-fruits. Kukhona lama-fruits vele sazi ukuthi uma umpatient diabetic awadla ushukela uyenyuka. Yimaphi lawo ama-fruits ongathi mhlambe ama-patient ane-diabetes kufanele bazame ukwa-avoid. Ngoba le nto iyahluka. Siyazi ukuthi kukhona i-fruits libalulekile for ama-kidney. Kube khona i-fruits ukuthi idamage ama-kidney. Libalulekile for inhliziyo. Usibalansa kanjani lezinto umuntu onoshukela bakithi yazi kuba nenkinga kubantu onoshukela ukuthi babalanse kahle ukudla kwabo.
Yes, definitely. That's why it's important. Once you are diagnosed with diabetes, ask udokotela wakho to refer you to a dietitian. But if you want a dietitian, you can always go to a dietitian and then also present in that way. Now with fruits, all fruits essentially are right. You can have fruits. It's okay to have fruit because they contain so many nutrients and they're great. But with umuntu diabetes, siyazama ukuthi encourage ukuthi fruits than the more sweeter types of fruits. Or alternatively, what you can do is try and get fruits like override, because those tend to have a higher amount of glycemic. Quite directly than if they right that much, and they contain more fiber, which will help to regulate your sugar nicely. Also, I have to mention also fruit juice. Fruit juice is fruits, it's like fruits, it's the enjoyable juice. But it's going to be very important for us to try and dilute the fruit juices whenever we are having it. Right? So if you are having a glass of the fruit juice, always make sure that half of the glass is water and the other half is always the fruit juice, because it contains a lot of fruits. Can you imagine like a glass of the orange juice, just one? It's more than one fruit that makes up that orange, right? That glass of orange juice. So it's a lot of sugar all at once, and it's going to affect you. So then that means also if you are just sitting, it's a normal danger when you want to have fruits. Don't sit and then say I'm a fruits. 3 fruits all at once, apple, orange, banana, all at once. It's putting too much sugar all at once. It's going to salt sugar now straight. So always have 1 fruit at a time. Yes.
Okay. Ake sikhulume la ngama-processed milk, processed meat. Umuntu onesifo soshukela uyawadla noma awadla. And ngicela ukuthi bacacisele abantu ukuthi masithi processed meat sikhuluma ngani.
Yes. Okay. What I normally tell my patients first, what are processed meats? Processed meats will be any type of meat. Ultimately, we are celebrities, right? You're not sure about the body part, from which body part of the animal it comes from. For instance, like evos, right? You cannot say when I'm having evos. Of course, you can say it's beef, but you can't say it doesn't come from the shoulder, it doesn't come from the leg and all of those things. Because in the factories, what they do is, but after the bits and pieces are saved of the meats, they will process some more, add more fats, add more sugar, add more salt, all of those things for taste, acceptability, so when you are eating you're already taking in very food that we are trying to avoid for your own diet. So in terms of processed foods, we really please try to avoid processed foods. Processed foods could be evos, could be Russian, sausage, Vienna, burger patties. The list is endless really. Even meat counts as processed meat. But if you can choose the lean type of meat, it means that that's a healthy alternative because they remove the fat, and the fat is something that we're worried about. But of course, uswai and other additives are also still there. Yeah. Okay, but even even polony is not the best thing. Okay, ham even is not good. So basically, sure to come from which body part. It's a red flag.
Kodwa manje sekunenkinga lena sho ukuthi lo muntu angeke asaye emahhotela mos. Asa-enjoy life mos.
It doesn't have to be that way. I mean, 2022, yes, 2022. Restaurants, they know people are more health conscious. People want new things. They don't just want inyama, they want a certain type of meat, a certain type of cut of meat. Even with bread, rice, most people are sometimes rice and no basmati or brown rice.
So not just basmati is safer.
It's safer, yes. Even all brown rice.
Okay.
Yeah. So what I'm trying to say is most food establishments already tend to cater for different tastes or different preferences in diets. So if you just ask, what's high mina actually alternative, you find most certainly what they do. Just ask.
Asithi njengoba bendlovu unefamily unabantwana kuyathenga imbuza kuyathenga ama-ice cream uthi ifamily advise ukuthi ithenge lezi zinto noma nabo kufanele vele kungasathengwa la endlini nje sonke sibe diabetic ungathini.
It's always nice. I always believe, even it's always nice to see family your support. Whatever So yes, it's difficult to bomb about the change in their lifestyle to accommodate you. So I would advise family to try. Right? But also now as a patient, as podiatrist said, even you as a patient, you are the doctor. So as much as a kaya, they can be buying more ice cream, buying all of those things that don't take. If you need to also then make your decision, you say, no man, I'm doing this for my health, for my survival, because I have these and these goals. And
kakhulu sisingubanda sesibhoxa nje uEric ngifuna uvalele ababukeli emakhaya ngokudaba lokuthi sihambe soyenza ama-over the counter medication while anesifo seshukela ukuthi ungabaluleka uthini laba abathanda i-over the counter medication.
Yeah, good. Most of those medication, the over-the-counter, the safe, and the figure level labor, the classifier as over-the-counter, if used properly. So the main thing is that they need to be used properly. The overuse of some of those drugs, especially without consulting a pharmacist. So normally when you've got problems, let's say it's a pain issue that you've got, then try to engage with the pharmacist, explain your conditions also, so that who could decide on what to recommend for you and what dosage to use. So I wouldn't say every over-the-counter medication is harmful, particularly the registered. Maybe I should emphasize on that, because you do find some of the complementary medicine that and they do say so. Medically able to say this medicine hasn't been evaluated by the regulatory authority, and most pharmacists will take the pain to familiarize themselves with that, or are comfortable to give them out, and wherever feel this is likely to be harmful for you, they will advise you otherwise. So challenge intervention here a professional, so they just pick up, put it in the box, just because maybe they just join up onto that. So yeah, the main thing is to consult, even if it means waiting a little bit of time to engage with the pharmacist on duty there, rather do it that way than go with the a DIY, because I think the other thing that happens, which we do find a lot with patient care pharmacy, they've already done a Dr.Pru kind of search thing, but diagnosing the owner, and then when they walk in there, they just want what they've read about it. Because if they can engage, there's nothing wrong to say, I've Googled this, am I in the right track or so, then because you allow a trained professional to evaluate what you want to use. So, yeah.
Okay, if your advice.
Okay. Whole neglected. On the face, so the first basic things will happen out every day so if you have a family member who can help you cut the nails, you can help. Then whole the patients I don't worry, because we can have it dry, hard, so if you don't know the problem, you can see a podiatrist, sometimes 6 weeks, 4 weeks consultation, you cut, you don't cut, and then here another thing that people don't moisturize the feet. So so it's a cream even under the feet. And it's in between because who moist the whole, but under the feet it's every day. Hold a diabetic inspector every day. Hold on the socks. Because some of these shoes crooked and jones or these are the hard layer. So it is already and the socks are like a cotton socks because it's breathable. So you put on cotton, it's silk, they sweat. And then if winter, you don't expose your feet to heater, double socks. Then expose them to a heater. Even extreme cold, because they know tie over winter because blood supply sometimes is limited. And then shoes. However, that's preferably lace up shoes, so that if you are too tight, you can loosen them up. So you actually lace up, try to get soft leathers, try to ask, you can even come to a podiatrist to ask, I'm having a problem here, and then the other main thing is, when you grow up, prevention is better than cure. Anything that you see, this could lead to a problem. Especially because another thing, any condition that you can takes long to heal. It takes long to heal. Sometimes these peripheral neuropathies, maybe lack of vitamin B12 or what, we can reverse them. But if you wait where the damage is continuing for long, it will problem. And ultimately, the number one thing to protect them out how we check together, well-controlled diabetes, and even if you have high blood, cholesterol, but anemic, all those conditions, sometimes they do the same thing as tricky. So when you have all of those things happening in the body, it's too much. Another thing, polypharmacy. Especially for you are call it diabetes, you're already taking your medication, your high blood, that means you can take 4. Then you go buy extra things. And then another problem you have from us is so what happened like move panalo a white when I move a red. And then that's why now all my patients get to bring your medication for your first consult. So that if you're already on pyridoxine, I don't repeat pyridoxine. Because sometimes patients are like almost that's what they say. So other than honest, because the pills are already knowledge of not only because of this medication going up. So another leading cause referral polypharmacy. So this is the whole this the arms are high blood, when high blood, maybe no right, I can no farm press, I just want to communicate. But I figure get some time, but it's not the same thing. We find that some of these neuropathies actually come from the treatment. Okay.
Niyazivela polypharmacy le treatment umuntu azathi senginekhabethe eligcwele treatment uthi uyabuka kule khabethe kugcwele into ezirepeatayo and uyaphuza uthatha lapho so mbukeli lapha ekhaya polypharmacy yiyo futhi elidela kule peripheral neuropathy sesiyayixoxa manje ngifuna ukuchazele odokotela ama-colleagues ethu ukuthi kungani kubalulekile ukusebenza multidisciplinary kungani kubalulekile ukuthi sithumele ama-patient kunina kusese-AS occupational therapist.
The human body is very complex.
Yes.
And whatever we're studying in our own respective fields within the health profession, it's specific to what we've been trained to do. Does it make sense?
Yes.
And pulling in expertise. So I'm seated here, I'm listening to a podiatrist, pharmacist, and a dietitian. I'm learning so much just within this session of things that I don't know, right? Because you can never say within the health professions you know. I always say that the most dangerous health professional is the one that they think that they know. Central to what we're doing is a patient getting better. And also what is critical is the early intervention of whatever that we're doing. Because what happens sometimes is that abantu bayatreata but by the time they are referring, there's little that you can do. And once you start taking history to a patient, you feel like there's been so much missed opportunity to totally reverse the conditions that we have. So by not referring, you are not necessarily taking now out of a job more than you are actually impeding or delaying or distracting a total recovery in the patient here. When in doubt, pick up a call and say, within your scope of practice, do you think that there is something that you can do to assist this patient? If you're not sure if an OT or a podiatrist or a dietitian can actually intervene. But the most important thing is that it must happen as early as possible. And also sometimes, because you see a high number of patients within a very short space of time, you'll find that then in therapy, there is so much time that is allocated to a patient that stuff that has been missed during consultation actually comes up. And now we are then able to say, actually, doc, I think we're dealing with this more than this because I've spent almost 2 hours observing this person doing their work. I'm picking ABCD, and a lot of diagnostic clarity that comes in during that process. So I think that a lot of conditions are manageable, and a lot of conditions are reversible. From your neurological conditions, I mean, things have changed since during our training. There's certain conditions where you're told that if it's a spinal cord injury, and so on and so forth, there's new treatment techniques that are coming in. But the early intervention becomes critical to say that we treat these people as soon as we possibly can. And just also in conclusion, The issue of multidisciplinary treatment is not having a file and then you forget as a doctor, and then you say. Multidisciplinary treatment is when the group of health professionals actually discuss and share their insights within a single particular case to say, what is your approach? What did you see within your consultation? And that is what a multidisciplinary approach is. Not a single person being seen by a group of health professionals at different times. It is the interaction and the sharing of skills and the combined clinical reasoning that actually is effective and for a better patient care.
Wayiqaqisa uRithabile okusho khona ukuthi singabodokotela singabahlengikazi and different specialists asingagodli ama-patient asingahlali ne-patient until izixake ukhona usuyithumela kwabanye. The more involved sisonke sisebenza sisonke nge-patient yinye yilapho ezokwazi ukuthi i-patient ithole usizo ngokuphuthuma ingakaze i-complicate. Uthe omunye ebhala lapha ku Facebook wathi ukuthi ngina 15 years ngihleli upractice akusho ukuthi I'm an expert on that. So sebala lapho nisale kahle siphinde sitholane next week same time 9 o'clock ngoSaturday ezempilo zomondakalo nisale kahle babukeli emakhaya.